This trigger film was developed for health services to use as part of an experience-based co-design process, EBCD. EBCD is a patient-centred quality improvement process. The film is intended to get local people, patients, families and NHS staff talking together about how they can jointly improve people's experience of health services. You can find out more about this process and how to use trigger films by accessing this link to the EBCD toolkit. This film draws from several interview collections about people's experiences of a variety of different health issues and conditions. The interviews were conducted across the UK by the Health Experiences Research Group at the University of Oxford. It includes people talking about what it's like to be an inpatient on a general medical ward, the ward environment, privacy and personal care, feeling cared for, involving family and friends, communication and coordination, and going home. The full interview collections can be seen on healthtalk.org. We'd like to know more about how you used this or other trigger films in the collection, and would be grateful if you would spend a few minutes completing the feedback form. The link to this is on this page.
Now, a day before when I went to I had a letter from the hospital with a list of things to take. They were very minute things, like your toothbrush, toothpaste, pajamas, towel. And again they said, even if you can't, the hospital will provide that. They only suggest that because we are more personal, it is better to have our own things with us. But it was not a big fuss as such. And the staff is always helpful. They even brought me the pajamas, and I said, no, I have my own. And so they were happy. So there was nothing much to worry about. They took full care of me.
I was taken to the hospital, instantly taken and seen, and the rest of the evening is a bit of a blur, really. There were a whole series of tests. Different people came in to see me, questioned me about various things, and I felt good. I felt pretty desperate to get out. I didn't want to be in hospital. You know, my natural reaction was to get out, almost at whatever cost. Really, I didn't want to be there. But the help I had was terrific support, terrific, talking me through every stage and what the tests were for. Similarly, in the hospital, I can't recollect being kept waiting about unavoidably, and every step of the way was clearly explained. Every test was clearly explained and the reasons for it. Not necessarily the results, because the results might take, if it was a blood test, it would take a while to analyse, but the reasons for it. And then being kept in hospital for 3 or 4 days, again everything was clearly explained. The barrage of tests I had was so comprehensive that, yes, I wouldn't have the knowledge to know if it could be
being taken seriously.
Oh yeah. And yes, it was being taken seriously, and I could see from the way other people were being treated that just the same was happening there. You know, they give you an evaluation sheet to fill in, don't they, when you leave hospital, and I couldn't be more complimentary, really.
I had banking to do, I had rent to pay, I had all kinds of things that I had to deal with. I mean, life goes on. Either you die, which I very much wanted to do, but I couldn't figure a way to do it because I couldn't get into a car and do the exhaust job on myself. So I thought, if I'm going to live, then I'm going to do the best I can with it. I had to deal with all this stuff. So I eventually got a hospital social worker to come. Mm-hmm. And I explained some of these things to him. I had to move my car, for instance. It was being vandalised. It was out on the street. I had to have it moved. So, all kinds of things like that, just practical issues. So I got this guy and I explained to him the problems that I had. And it seemed everything I brought up, that I need money, I need to do banking, I need to pay my rent, I need to blah blah blah. He'd just say, oh, we can't touch money, we can't go in your house. And I'm like, well, what can you do then? And in the end, nothing.
I had the stroke on a Friday evening, so I was admitted on a Friday night. Obviously on the Saturday and Sunday, the normal medical staff were not working, and therefore I was not admitted to the specialist stroke unit until the following Monday. So for most of the Saturday and the Sunday, I was in a normal medical ward and received virtually no treatment at all.
And I just remember sitting in the room and waiting for them to do me, and it seemed to be them. At the time, it was very normal for these people to do these things. So this is a traumatic thing for me. I'm the only person in hospital here. Get me done right away, and that's how I was feeling. But these young nurses, they came in and said, "Made you welcome, and you come now. We'll do this, we'll do that, and turn this way, turn that way. I would do anything, just get me out." Yeah. And that was the feeling I got, that, God, these people do it every day. I'm not the only person in the hospital. These people do it every day. They see these things every day, but this is an experience for me. You leave all your dignity at the hospital door when you go to the hospital, and don't get me wrong, the nurses were fantastic. They don't bore. I was more bored than they were. But dignity is a great thing to have, and to lose it, this is not me, And I was determined, as soon as I could, I would do these things for myself, go to the toilet myself and clean myself, things like that, because it is a terrible thing if you're not used to this.
When someone comes in and they see something or feel something that is familiar to them, it helps them to feel comfortable and relaxed. And then your interaction with that person is better. They come away with something more. And this is what services don't do. They don't. It can be as simple as a smell. I've had people come in here, and when they're doing the training, and the caterer comes, and the caterer comes in and he brings rice and peas, and a man walked in, he said, "Boy, smell like home." Do you know what I mean? It's these little things that can make somebody feel like, I actually belong here. They have some kind of insight into my world, and they appreciate it. Moreover, they appreciate it, and I think that's what's missing. It's hard. It's not. Don't get me wrong. It's not an easy thing to do, because we spend quite a lot of money on trying to achieve that in the project. It's costly, but it's worth it, because then that person who may be Asian, Chinese, African, Jamaican, some other West Indian country, wherever they come from, will go away with this really warm feeling about your service or your project.
How about you? Have you experienced racism, do you think, at the hands of the system?
Kind of not in a vicious way. People are making assumptions that because I'm partly Asian, that they'll just automatically assume I eat curry and speak Urdu or Hindi, and I can only speak English. I can do some sign language, but I can only speak. They kind of assume that, they're helping by, but they should, you should ask first. Don't speak to me in Urdu and assume that I understand. It's very silly, really. It is.
So that was that. So that was the reason. So I did have this purebred diet. So your plate would just have different coloured splodges around the plate, basically, on there, depending on what it was that you were eating. I think the worst was Sunday lunch, where you'd have a brown dollop of sludge on your plate, which was my roast lamb, I found out. Then a green piece, which was the cabbage or the peas, and grey, which seems to be the colour of potatoes in that particular hospital. And now you'd be expected to eat that, but I just take the lid off, put the lid back on, so you can take that away. I'm not eating that. I used to ask my wife to bring food in for me and my other visitors, and live mostly on chocolate bars and desserts from supermarkets.
I'm a pure vegetarian. No eggs, no fish, no meat. So they do give their special diet in the hospital, although it is not to our standards, because they may not have the good staff in that particular section. Otherwise, there's not a problem. because we live on a very, very simple diet. And so normally for me, my wife used to bring everything from home. I was even given special permission so that she can keep things in the fridge. She can make tea, coffee, anything what I need, just like my home.
The lids on the bins, the lids, you could hear the lids on the bins. Well, when I was sedated, I could hear these big bangs, and it made me jump, and it made me frightened. And
it made me jump a few times when I was asleep of a night.
Yeah.
I didn't get any sleep at all because I don't know why, the light was on. I just didn't get any sleep. The Thursday, I didn't get any sleep when when they took me into that room, because the fluorescent light was on ahead on top of me, adjacent to me where the sluice room was. The fluorescent light was on. On the left-hand side of me, there's a door with a light shining right through.
I would like to have had him home just to be peaceful, because Fred was on the ward. There was no little room available for him at all. They were all too full up. We were on the ward. We were by the nurse's station. They had the curtains around him most of the time anyway. But this particular day that he died, oh God, it was horrendous. They were hoovering, they were shouting, "Do you want tea? What do you want for your dinner?" And we were behind the curtain, and there was Fred being injected because he was, you know, getting worked up, and they were trying to keep him calm. Every time the curtains opened for somebody to come in, everybody was sort of looking, oh dear, that was awful. It really was horrendous. And I said to them, "Isn't there anywhere, please, you could put us?" And they said, "No, there isn't. We're sorry, all the single rooms are available." There was a room that, should we want to stay overnight, which was in the corridor, that we could have slept there because there was a bed in there. I said, "Ask, can you go in there, please? Can you put him in there just to have a bit of peace to be with him?" And they said, "No, we couldn't." And he actually died on the ward, and just we had to walk away and leave him there with the curtains around him. That I find, oh, that haunts me.
Privacy and dignity, I think, remains a challenge for the National Health Service, and much as with health information for patients, I did encounter some truly fantastic practice from some truly admirable practitioners, but I also had some exposure to the other end of the spectrum, people for whom privacy and dignity for patients is clearly not a particularly dominant concern. There were occasions when, whilst going through some pretty undignified procedures, either with the biopsy, for example, or the cystogram, for example, there were occasions when doors were flung open and people would just walk in and out and not introduce themselves, and they clearly had nothing to do with what was going on with me. And whilst I can tolerate that up to a point in a dentist's chair, if a dental nurse walks in and out, it's quite different from when, put bluntly, your ass is sticking up in the air. So I firmly believe that that has nothing to do with resources. It has to do with personal choice, personal practice. It has to do with training. It has to do with culture. Perhaps it has also to do with managerial performance management practice, because these things go on because we work in a system that allows them to go on. And if we stopped allowing them to go on, then they wouldn't go on. So it's at that kind of level that I think that privacy and dignity are not always well attended to, although I hasten to add that I did have plenty of exposure to the other end of the spectrum as well, some really admirable clinicians and wonderful human beings who did a first-class job of plying me with information and also of attending to my privacy and dignity. They deserve the credit, but I'm just making a particular point about what I hope would be the minority of people at the other end of the spectrum, but it's a minority that can make a fundamental difference to the patient's experience of the process of care.
I think there must, as I've said, there must be taught that each patient is an individual. They're very vulnerable, they're very sensitive, and what they want is kindness. They don't want to hear, oh, I'm too busy to bring you a bedpan, or get up and go, you'll be all right. I mean, they kept saying, you can go to the toilet. And I said, well, look, I can hardly walk. I will have wet myself by the time I get there. Well, you shouldn't have to say this. I mean, patients know whether they can get out of bed and get to the toilet in time. But to be told, get up and go, and having to explain, well, I'm afraid I can't. They should know this. They should know each patient and their capabilities.
So the next day he was a little bit better, and I think it was probably one of the low points. He was sitting in the chair, he felt sick, and because he'd been giving him sort of hot liquids, he had diarrhoea. Now, it's not conducive really. At visiting time, you have a curtain separating you. There's now a curtain around him because he feels sick and he wants to go to the loo. He's sitting on this commode with dreadful diarrhoea, being sick, and there's a woman literally 2 feet away from him. And it was so embarrassing, and I personally think it's degrading. So I called the nurse and asked if we could help because he was sick, and I tried to get him cleaned up, but I couldn't. We had to wait a long time. A, it wasn't nice for B, it was awful for me, and I'm sure for the people in and around it was absolutely awful. So from that point of view, that was very, very distressing. But they did, you know, they did look after him reasonably well, but they just don't have the facilities or the staff to do it.
And so I didn't sleep well. And I remember one of the nurses coming on duty and saying, I've brought this stuff for you, and it was lavender wash stuff, and she said, it says on it that it's helpful to sleep and it keeps you calm. And I thought about you because you've not slept very well, and I thought that was really kind. That she wasn't just washing me with whatever soap they had, that she'd actually gone out of her way. Another of the nurses got some shampoo for me and said, this stuff that we're using here isn't great, I've brought you some from home. Things like that made me feel they were not just nursing me, that they were becoming friends. And we actually had some good times.
And the kidney consultant came to me and said, I think you're very ill. It's not a kidney problem as such, although your kidneys are not functioning very well at all. But I'm going to hand you over to the haematology team because I think you've got multiple myeloma. He said this to me in the knowledge that I'd lost my husband only a few months before. He said it to me alone in a hospital bed, and I was absolutely furious with him. I said, you know what happened to my husband? He said, yes. I said, you can't be telling me this. What I meant was, he shouldn't have told me when I was by myself, behind curtains in a ward in the hospital with nobody to talk to. And I was desperately upset. I immediately rang a friend who came rushing up to the hospital to help me.
Do you think that information should be given?
Well, I think it should be given in the way that my present consultant has given me other news. He sits you down and he smiles at you, and first of all you realise that he's on your side, he's with you, and he understands you, and he understands you as a person. And when he tells you or gives you news, like when he gave me the final diagnosis, it was done in a way that, in fact, he held my hand, you know, and he told me, first of all, he built up to it. He didn't just blurt it out.
Initially, I didn't have a very good relationship with my consultant. He had the view of, you will do what I say, and not dare to question me. But once we'd had a little discussion or two, and we'd kind of evened out the doctor-patient relationship slightly, I didn't like being treated as a shell, as a disease. I was a person. I wanted to be treated with a little bit more respect and humanity. And perhaps I shouldn't have done, but I told my consultant that. And from then on, we've got on famously, and we get on really, really well.
I had a as I say, a heart problem, and lots of the doctors, the trainee doctors, were brought round on the consultants' rounds with them. And they'd come round each morning and draw the curtains and all stand round the bed, and it's like a little flock. They can walk in, they can be in the middle of your breakfast or trying to put your makeup on or trying to brush your hair, and they just come. So your breakfast goes cold on one side and they discuss your case, and they'll talk to themselves, but they won't interact with you. And I actually felt on one or two occasions like a piece of meat. I was very much treated as if I wasn't there. I like the warm, friendly consultants who would make you laugh or come round and crack a joke, or just interact with you and show that, you know, they're another human being and that they're talking to you and you're not just a medical case on a bed, you know, bed number 5 in ward 8, whoever. I wasn't just an abnormality. I'm me. I'm not just a stroke and a heart complaint.
I think in terms of health professionals, it would be sit down and listen and talk to people. Being in hospital, if you've had a fairly independent life and all of a sudden you're taken away from your home, your work and your family and your friends, and you find yourself stuck in hospital for the best part of, well, 6 months nearly, you can be very isolating. I did feel very, very alone. It would have been nice to have thought I had a friend in the hospital somewhere, other than my visitors that were coming in to see me. And apart from the physiotherapist and the one occupational therapist, there was no one I would have turned to or talked to. And there was actually times on the ward where I wanted help, and I didn't feel there was anyone there that I would ask, that I felt comfortable to ask for help. Sometimes it's very difficult to ask for very personal help if it's something you're not used to asking for. Even though it's something you obviously need, it's difficult to actually ask for it. Well, I certainly found it so. And so did other people that I was on the ward with, other patients. They didn't like asking for their help. That was very difficult. And perhaps I shouldn't have to ask. Perhaps the healthcare professionals should be understanding enough and trained enough to know that they need to be offering that help. Not having to wait to be asked all the time, and just sit down and see people as people, not just as stroke victims or stroke survivors, which are not terms I particularly like, I've got to be honest.
Oh, the nursing care was second to none. This was epitomised by one particular incident where I was at a very low ebb in the middle of the night. I was coughing and was to the point where there was tears coming out of my eyes, and I just couldn't breathe, and I was very, very distressed. Now, there was a nurse there, and she was rubbing my brow, and so much so that I had the feeling that it was my mother looking after me. It's strange things that crop into your mind, but she was like that. She was. I said to my wife several times since I've come out that that's not the type of thing you can teach somebody. That's the type of thing that you either have or you haven't got. And yes, it epitomised the type of nursing that I received.
Beware, some of you medical staff, that you can so easily give the wrong impression. You can so easily give the impression you'll be glad when your shift finishes, or that you're looking forward to your lunch break or your tea break, and you'll come back to see to your patient afterwards. Now, that is scary. And it was scary early in my stay on the general ward, when I was still dependent on being hoisted both out of and into bed. And if you don't get the timing right as a patient, you find yourself literally stranded. So I have been chair bound for 12 hours, and that is very, very frightening. Nobody there to give you reassurance. Your family has gone, those who were sort of giving positive support. And you realise that I realised that I didn't like necessarily all the nursing staff. There were some I really adore because I saw that the quality and the love and care shining from them. But I was ultra dependent even on the people that I didn't like or took an instant dislike to, some of which couldn't be substantiated, but that was feeling, and feelings are difficult to handle.
They've been outstanding. I have been really, really fortunate with the health professionals that I've had, and actually, you know, as I come across yet another excellent chemotherapy nurse, you have to assume that this is the standard. You know, I can't just be lucky with every single NHS employee I come across. The nurses, do you know, one of the things that makes chemotherapy nurses, I think, seem really really good is, I don't know whether they have a skill of remembering detail about people, or whether they're just very careful to look at people's files very closely before they see them. But you know, they knew my daughter's name, and you know, when I went back, they would ask after her, and you know, they see thousands of people, so there's absolutely no reason why they should remember her name, but they do, and it's that kind of personal treatment that makes a big difference. When you feel like somebody has personal investment in you, that's a very important thing. And I think that the nursing staff, you know, to a man and woman, were that good, you know. And you do feel like you're being, you know, that they're willing you to get better, you know, their willingness to be successful. And it's true of the admin staff as well, you know, although I think sometimes clinic arrangements could perhaps be administratively enhanced, but you know, that's just the way it is.
Do you have any children?
No children.
No children. No. So how has that shaped your experience?
Oh, very much so. Partly because this perception that other people have. I constantly looking at commentaries about health conditions on the computer or leaflets or whatever that talk about get your family to do this, get your family to do that. Hello, I haven't got family. What about me? And that's a familiar thing, that you're supposed to fit a certain profile, and if you don't, then there's no answer.
I woke my dad up again, and I got him a drink, and I said, I'll be back in a minute. I went out, and there was this junior doctor on the ward, and I said, I train as a nurse. Can you tell me what my dad's hemoglobin is, please? And he said 7. So I said, so when is my dad getting a blood transfusion? So of course they had to do it.
We know that all of us have got things wrong in the past. The wheelchair user used to complain that people used to address the questions to the person pushing the wheelchair rather than the person using the wheelchair. Does he take sugar syndrome? I think we've actually perhaps gone too far the other way. There are times when, if a healthcare professional is talking to a patient, this is a difficult one, I do appreciate, that a relative or carer may be trying to intervene, and that intervention may not always be appropriate. It could be that they've got their agenda or their view or whatever. But they do need to be aware that there are conditions whereby the patient cannot communicate easily and need to pass that responsibility to somebody else. Once or twice I've had to be less than gentle in the way I said, I'm sorry, you do not know what you're doing. Please listen to me.
said, they've taken him onto the wards, Jill, you know, and I said, oh, I better go down, because at that time, Mike's speech, there was probably only myself, really, who could really understand what he was saying, you know, because I'm with him all the time, I could still understand. So I went down, and the sister was on the ward outside of the ward, and I said, excuse me, I said, you don't mind if I just go into the ward, do you? I said, you know, the doctor's with my husband. I said, and you'll not be able to understand what he's saying. To which she responded, he's managing very well, thank you very much. So, and then the next minute the doctor came out and he said, Mrs. I said, yes. He said, could you come in? And he told me, I can't understand what your husband's trying to say.
One of the things that we know is a kind of after effect of diabetes is depression. Have you experienced anything you would call depression?
Oh yeah, when I was in hospital I was very. I mean, that's one of the reasons I was so glad to get out. I mean, partly because one of the problems seems to be that there's no nobody seems to be looking after you as a person, as a whole person. I mean, as I say, the individuals I've met in the NHS have all been absolutely brilliant as individuals, the doctors, the nurses at every level. But there's nobody, when I was in hospital, sort of looking after me. So I was sort of bunged in a bed in a ward, and I was surrounded in the ward by people with amputations in wheelchairs looking incredibly miserable, most of them somewhat older than I was, and people with coming in for, I was there for 6 weeks, but most of the people just came in for 2 or 3 days. It was pretty clear, although nobody said it to me, that one of the possible consequences would be to have my foot amputated, and that was obviously, and I got suicidal basically. Luckily one of the SHOs had a bit of spare time and got talking to me, and she helped a bit. She must have had a word with the registrar, because the registrar came back and sort of gave me some other options. But that was, you know, yes, I was very depressed.
One doctor came along and said, don't want you to get out of bed at all. Now you stay right there and you do not move for 24 hours. Another doctor comes along. What are you doing laying in bed? I want you walking up and down this ward. I said, well, I don't know how I'm going to lie in bed and walk up and down the ward at the same time. It cannot be done, doctor. It can't be done. Well, Dr. So-and-so told me to lay in bed. You're telling me to get up. And he marched off, so he probably went and had a row with the doctor that said this before. I don't know what happened, but so I've compromised. I stayed in bed for a while and then I got up for a while. It seemed to work.
They decided in the last rehabilitation unit that I was in that I was as well as I was going to get and that I was ready to go home. And I live on my own, so I was going to go back home to live alone. It was a very strange experience to walk back into, well, this room, this house, which I'm very fond of, which I hadn't seen for months, full of all these things that looked like they belonged to somebody else. Because it really is like a bereavement, a stroke. I mean, it really was like that woman had died, the one that wore high-heeled shoes and walked around and ran a business and had a fantastic memory. If only somebody told me on New Year's Eve 1995 that that's the last day I would have ever walked like a normal person. Because I would have walked all day and I would have thought about how wonderful it is to walk. Because there isn't a day that goes by, and I'm not being negative, but there just isn't a day that goes by that I don't miss walking, because I miss it.
It would have been nice for somebody to sort of, a week after or so, make a quick phone call. Just to say, well, are you still alive, or what have you? I've had nothing, absolutely nothing, and I think, if it was just a case of somebody sort of gone in there for an ingrown toenail, yeah, you can understand. But as I say, I did actually
diet on respiration on 2 occasions, and it's caused some concern.
One particular nurse in a specialist neurology unit I was at he was the first nurse that came to see me when I went into the unit, and he was absolutely wonderful. He told me he'd had encephalitis, which is it water or swelling of the brain, and he'd been really poorly, and he'd been very lucky to survive it. And because of his particular, obviously what he'd lived through, his particular life, he'd gone into nursing, and he's obviously specialised in brain and neurosurgery, and he knew what it felt like to be in there. And he came over, and he was on New Year's Eve. We were there, and we all celebrated in our own way. And you know, he came over and gave me a cuddle and said, you know, next New Year you won't be here. You know, and it was just a really bonding, enriching experience, because there are so many wonderful people who go into nursing, and doctors and consultants who really genuinely do help and do make it easier. And there are those who obviously don't. Certain members of the medical profession who really hadn't got many skills in trying to understand the things you're trying to say to them.